Good morning, everybody, to our audience. My name is Тору Ito, Canada Medical University Division of Gastroenterological Endoscopy. Thank you for inviting me the 21st Russian and Japanese symposium. It is to be an honor of mine very much. In addition, so I'm a special thanks to Professor Karlov and other endoscopists and who give me an opportunity. Today, lecture's theme is cutting edge of accurate diagnosis of SM gastric cancer carried out. So, as a personal opinion, that is based on my experience that was just carried out for about 25 years. So, our university and the hospital located in the center of Japan and near the sea. And so this is our university. It's a new building, so. And then so about 10 years ago, so 10 so I came to with former president Mori and our university president and this is a memorial photograph. So the column of the left upper section, the memorial picture. When Canada Medical University and Medical University signed it for the purpose of the international academic exchange, the left lower column is a photograph when we performed ESD of the early gastric cancer with Dr. Kassim for the first time in 2009, December 2. So why is necessary for the exact depth of invasion? It does not need to say that it is necessary to judge endoscopic treatment or surgical resection. So in the AI diagnosis for the detection or depth of invasion of the early gastric cancer, judgment levels are caused by a form diagnosis by the white light finding. So one modality is endoscopic diagnosis possible in. So it is not say some other time, but it is very important to recognize the basic macroscopic type of the early gastric cancer. It's very important. So endoscopic imaging is important for the form diagnosis of the early gastric cancer. In endoscopic imaging, which Professor Tajiri and Nia was summarized as for the diagnosis of the macroscopic finding, white light endoscopy and image enhanced endoscopy are important. And image enhanced endoscopy, NBI, BLI, LCI, and angiocarmine as a contrast method are very important. So many endoscopic diagnoses are possible with white light diagnosis, dye method, image enhanced endoscopy. So as you know, the definition of the SM gastric cancer is just what was slide. The permission diagnosis of SM1 is said to be difficult for macroscopic finding. In other words, muscularis mucosa invasion within 500 micrometers. So it should be diagnosed by an objective indicator such as tumor size, macroscopic type, location of tumor, color of lesion, presence of nodule in the depressed region. So it is very important, difficult. So between SM1 and SM2, but it is difficult to accurately diagnose SM1 gastric cancer by endoscopic ultrasonography. The point of endoscopic diagnosis of depth of invasion in early gastric cancer, so it's very important. So tumor size and finding other image, wedge-shaped depression, marked redness, coarse nodular prominence, rough surface. So it's a point of misdiagnosis of factor. It's fibrosis and other things. So it means so type 03 it's factor of diagnosis. So the 70th Russian-Japanese Symposium, Moscow, 2015. So accurate diagnosis for depth of invasion and the area with NBI with magnified endoscopy. So about the histologic diagnosis of cancer, the area diagnosis of cancer, there are many articles, but there seem to be many papers based on Professor Tajiri basically. So area diagnosis may become easy in the NBI and BLI combination, non-magnifying endoscope views, and corrective diagnosis depth of invasion may be enabled in the magnifying endoscope view. So it is useful for histologic diagnosis and area diagnosis. Yes. It is effective for depth of invasion of early gastric cancer by NBI with magnifying endoscopic view. Therefore, the recognition of irregular vessel is important. Irregular mesh pattern means mucosal invasion. Also, we suggested SM deep invasion if interrupted pattern is recognized. So if irregular mesh pattern is recognizable, the diagnosis of mucosal invasion is easy. Irregular mesh pattern, so whereas the diagnosis of SM deep invasion is relatively easy, if interrupted pattern is recognizable in NBI with magnifying finding. However, unfortunately, it's my inspection, so we could not see subepithelial capillary network of the region of SM gastric cancer mostly. It is a case presentation, but the depression of 2A plus 2C type of early gastric cancer cannot confirm vessel pattern in dirty depressed area. So this case is similar to, unfortunately, many SM gastric cancers seems to be cannot confirm vessel pattern. So 2016, so yes, symposium. So a diagnosis of SM invasion is possible if we can confirm interrupted pattern in NBI with magnifying endoscope finding. However, we cannot confirm abnormal blood vessel, irregular vessels such as interrupted pattern in many cases as described before. We cannot but judge that it is diagnosed only in limited cases. So the depth of invasion of the oral gastric cancer by method of NBI with magnifying finding seems to be difficult under the present condition. It cannot be said that which is effective of exact depth of invasion depends on white light finding under the present condition. In addition to this, it may be said that US NBI with magnifying finding are beneficial as a supporting diagnosis. So it is honor. President Novikov got a prize from Japan. The Japanese name Kyokujitsu Sunrise medal. So endoscopic diagnosis of oral gastric cancer. So I said it is very important. So macroscopic type. So to recognize precise recognize macroscopic type. So first of all, in depth of invasion for oral gastric cancer, a judgment by the size of it is important. In addition, exact depth of invasion is enabled by diagnosis of the accurate macroscopic finding. So this case, typically there one type, so within the 20 millimeters, also limited to M. So resected specimen seem to be limited to M region. So this case is typically type 1 lesion, but we could see the irregular vessels, interrupted pattern on the surface of the tumor. So suspected deeply, SM invasion. So we try to ESD, but resected specimen reveals deep SM invasion. So this case was resected stomach with lymph node resection. So in this case, typically flat to a lesion, within 20 millimeters. Almost mucosal invasion. So this type 0 to a typical case within 20 millimeter, almost mucosal invasion. In this case, was typical to a confluent type 2A type, within 20 millimeters, depth of the invasion M. So it is oral gastric cancer, but 0-2A to plus lesion type to be careful in particular. Tumor size larger than the 20 millimeter means a higher frequency SM invasion, about 40%. So in addition, elevated change with submucosal tumor with no air deformity change means deep SM invasion, sometimes muscle invasion. So this is the typical 0-2A plus 2C lesion is recognized. 2A plus 2C precise diagnosis. This case means deep SM invasion. So this case is similar too. So this is located gastric angle less curvature. So fortunately, this case could be confirmed vessel pattern, so-called interrupted pattern. So deeply SM invasion. This case, finally, ESD was performed. And resected specimen, deep invasion SM2. This case, patient required to find first ESD, and then in this case resected stomach with lymph node resection, no metastasis. So in the depth of invasion for depressed type R gastric cancer, a judgment by the size is important. If other can confirm the view that's showed with pink, we can diagnose SM invasion. So the presence of convergence of the fold become higher in SM invasion rate. If other can confirm the view that's showed with pink, we can diagnose SM invasion. So this is a typical type of Del2C with fold convergence with fibrosis. So was rejected, so ESD. So this region, even if 11 millimeter in size, but SM1 invasion. So next case, this case is similar to located lower part of the body of posterior. So this region, patients require ESD. So we try to ESD, but this region rejects specimen deeply SM2 with lymphatic formation positive, vessel involvement, no involvement. But even if 10 millimeter in size, but deeply SM invasion. So this case resected stomach and lymph node resection, lymph node metastasis positive, and finally this patient liver metastasis 2 years ago present and died 1 year ago, one later. So finally, this is a summary. This film last year, December 12, I and our university president Takashima to Yaroslav University, Medical University, and then write medical internal medical exchange KMU to Yaroslav Medical University. And then 2018, March 30th, JRMF symposium at Moscow, Petersburg. That's all. That's also. Thank you for attention.